I think that this is good to review. We also have everybody new, so the guidelines are really heavy in terms of reducing cardiovascular risk in diabetes. These, when I refer to guidelines, I'm referring specifically to the American Diabetes Guidelines that were released in January of 2021, so this month. So we'll kind of just go through this, and there's some cases embedded within this. If you have questions, just stop me as we go. So I think this is a little bit more exciting than the other PowerPoint too, because it's just really me reading the guidelines, whereas this is a little bit more interactive. So we'll start with true false quiz. Are you all able to see my screen okay?
Yes, we can. It's not in the PowerPoint mode, but so we can kind of see the next slide, but that's totally fine. We can see it.
Okay. Let me put you guys in PowerPoint. Better?
That's perfect.
Okay, so let's start with true false quiz. Are there diabetes drugs that reduce your cardiovascular risk? Yes or no? Let me open up chat. True. Good job. Yes, true. Are there diabetes drugs that are approved for primary prevention of cardiovascular disease? True or false? It's actually true. We'll talk about the FDA approved drug called Trulicity. It was approved in April of 2020 for primary and secondary prevention of cardiovascular disease. Are there diabetes drugs that improve renal function? True or false? That is also true. Okay, so moving along, and we're going to talk about all those true or false questions in depth. So no worries if you didn't know, you'll know by the end of this talk. Okay, so big picture, what's new in the guidelines in 2021? There are now dedicated decision pathways for patients that do have diabetes and heart failure or atherosclerotic cardiovascular disease and chronic kidney disease, which is really exciting. So our objectives, we'll discuss anti-diabetes agents that reduce cardiovascular risk and improve kidney function. We'll focus on GLP-1 receptor agonists, that stands for the glucagon-like peptide, and SGLT2 inhibitors or sodium glucose transporters. We will review the agents, we'll talk about the mechanisms of action, the benefits and risks, and become familiar with all the updated Diabetes Association guidelines. So why must we act? Atherosclerotic cardiovascular disease is the leading cause of morbidity and mortality for patients with diabetes. This is comprised of coronary artery disease, cerebral vascular disease, and peripheral arterial disease. There's 37 billion in cardiovascular related spending per year associated with diabetes. This is the New England Journal article that came out of Cleveland Clinic. Dr. Steve Nissen had published it. And this looked at the effect of rosiglitazone on the risk of myocardial infarction and death from cardiovascular causes. This is really what prompted cardiovascular trials in diabetes care. And this was a really good thing because all new diabetes drugs that are introduced to the market now have to undergo rigorous cardiovascular testing, and it really started here in 2008. So since then, you can see the busyness of all of this, and you can see today we'll focus on cardiovascular drugs, but you can see all the drugs even since 2013 to 2020, all the drug trials that have been done to assure that the drugs released for diabetes do have either a benefit or that they're not harmful. We'll focus on some of the pink and the orange trials today as we talk about the new guidelines. So just as a refresher and a slide for your reference, these are the non-insulin diabetic medications in the United States. Again, I'm going to focus on mainly the SGLT2 inhibitors and the GL1 receptor agonists because they are the drugs that reduce cardiovascular risk. They are great drugs that also help with appetite and can help with weight loss. So we're going to mainly focus on the left side. These are the new standards of medical care for diabetes. They, again, published in January of 2021. You may note that this table looks familiar. The ADA guidelines have really always had this, but the new features in the last few years are basically the fact that they introduced cardiovascular effects. So when we're writing diabetes agents, do they have a harmful risk? You know, are you putting them on a DPP-4? And is it harmful to patients with heart failure? You know, you can see increased risk with DPP-4, increased risk with TZDs or thiazolidine diazones. Sulfonylureas, some people may argue that there's an increased risk. Sulfonylureas do predispose to hypoglycemia. So you can notice that this is a really helpful column. Similarly, they tell you, are there benefits if your patient has atherosclerotic disease or heart failure? I also want to point out in highlighted portions the renal effects as well. Benefits and risks, again, because like I said, there are drugs that improve renal function, and we will go through this in depth. So if we zoom in specifically on our GLP-1 receptor agonist class, that's going to be drugs that are mainly injectables that you've heard of. So that's Victoza, Ozempic, Trulicity. Some of the older drugs were called Byetta, Bydureon. And so these are mainly injectables. There is now one oral agent on the market called Rybelsus, and that was recently introduced. So these drugs are great because they do not cause hypoglycemia. They help with weight loss. They have cardiovascular benefit. We're going to go through some of those trials that detail that. They are neutral. They do not harm patients that have a history of heart failure. They have incredible benefits on the kidneys. They reduce proteinuria. They have been shown to lengthen the time a patient with CKD needs to go on dialysis. So many different renal benefits as well. The risks that you should know of to kind of point out to your patients, worst case scenario is pancreatitis. Many people develop nausea and vomiting with these drugs, but when you start at very low doses and titrate up slowly, that is a way to avoid the nausea and vomiting associated with them. So, excuse me, I typically write for the once a week drugs for compliance purposes, and who wants to inject a drug every day when you can inject weekly? And the weekly agents are Trulicity or Ozempic. Those drugs, we start at low doses. So I can't really tell you the doses because they're specific to the drug. But say that you're starting with Trulicity, there's 4 Trulicity pens now. So you start at the lowest dose, which is 0.5 milligrams, and you would do that for 1 month, and then you slowly escalate in 1 month increments until you're at the highest dose, the 4th pen. And that really helps try to circumvent the GI side effects that a lot of patients may get. It is contraindicated if your patient has a history of pancreatitis, and I would tell you to go slow and be cautious in patients that have gastroparesis. Also worth discussing with your patients is that it did have the black box warning, which you can see over here in the additional considerations. FDA black box warning for risk of thyroid or C-cell tumors in rodents. It's never been proven in human trials, but nonetheless, I do explain that to all my patients. Oops. So to look a little bit more in depth at the GLP-1 receptor agonists, the good about them, they improve renal function. They have FDA approval for both primary and secondary cardiovascular prevention. They help with weight loss. Again, the once a week dosing is with Trulicity and Ozempic. There's no hypoglycemia associated with these drugs, but remember, if you're adding on these drugs to someone that's already on a sulfonylurea or insulin, you can have hypoglycemia. But a patient that's only on a GLP-1 agonist, that drug itself does not cause hypoglycemia. These drugs help with both blood pressure and lipid lowering. The bad, we talked about C-cell tumors that was noted in rodent studies. We talked about the GI side effects. I think one of the biggest curveballs is the expense of it. So getting prior auth is always challenging in these cases. I hope that changes in the next year with evidence-based medicine showing that they really do help with primary and secondary cardiovascular prevention. One of the drawbacks is that it is injectable. Again, I told you there's only one oral agent called Ribelsis on the market. So it's injectable, and injections are painful and cause injection site reactions. So that is a drawback. The incretin drugs, this is a slide for your reference to become familiar with them. Victoza, Trulicity, Ozempic. The generic is on the left side and the brand is on the right. Exenatide, exenatide extended release, lixisenatide, the oral semaglutide, which is called Ribelsis, and albiglutide is now off the market. So what is the big buzz behind incretins? There are two main incretins when we talk about the incretin classes and the incretin effects, and they're called GLP-1 and GIP. As you can see up here on the right-hand side, GLP stands for glucagon-like peptide, and GIP stands for gastric inhibitory peptide. The way the drugs work is that these incretins stimulate insulin release and inhibit glucagon release. So they together work to lower your blood glucose levels. You may be familiar with the drug class called DPP-4 inhibitors. The way that those drugs work is that they block DPP-4 enzyme from inactivating and breaking down your incretins. So that is also an agent for diabetes care. I'm not going to go in depth on your DPP-4 inhibitors today. We're going to focus mainly on the incretins and the SGLT2 inhibitors, again, because those have the strongest data of cardiovascular benefit in our diabetes population. This is a summary of incretin action on different target tissues. So you can see they have a multitude of benefits. They're neuroprotective, they decrease your appetite, decreased gastric emptying, which is somehow also how they can exacerbate gastric emptying, patients that do have gastroparesis. So you want to be aware of that. They increase insulin secretion, they decrease glucagon secretion, they increase your insulin sensitivity, and they're cardioprotective. Again, a multitude of effects on the heart and myocardium. Down here you can see that they increase glucose utilization, they decrease fatty acid utilization, increase coronary flow. They have a multitude of benefits on the heart. This is a really complicated slide of the kidney, and it's not meant to kind of go through the whole physiology of how GLP-1s work, but it's simply to bring your attention to the fact that they also have a multitude of benefits at the level of the kidney and lead to afferent vasodilation, which in turn reduces your glomerular hyperfiltration, so in turn reduces microalbuminuria and kidney damage from diabetes. Case 1, this is John, clogged artery. It's a 64-year-old male. Comes in for severely uncontrolled type 2 diabetes. A1C is 11.2%. He had diabetes since 1997. His BMI was 29. He's overweight. Vitals are stable. He has multiple complications of diabetes, including peripheral neuropathy, dorsal foot ulcers. His kidney function is reduced at 35. He has a really significant cardiac history that you can see there. AFib, coronary artery disease, CABG, ischemic heart failure. He has an ICD in place. He has pulmonary hypertension, sleep apnea, high lipids, Hashimoto's disease. And he came into the hospital with decompensated heart failure and was on diuretics that were titrated up. This is actually a patient that I saw in my clinic. All the cases are my own patients. And so his current regimen was Lantus, 75 units twice a day, Humalog 10, 3 times a day with food. His fasting blood sugar is 200 to 300, and then throughout the day he's having low blood sugar. He hasn't had diabetic education. His wife comes with him. He eats McDonald's fast food 3 times a day. So along with diabetic education, what is the next best step for this patient? So would you increase insulin? Would you add metformin? Would you consider a GLP-1 receptor agonist and reduce insulin to eliminate lows? Would you begin an SGLT2 inhibitor and reduce insulin to eliminate lows, or do you ban him from McDonald's? No answers are wrong. We'll talk through all of them. So I have a chat for C and E. Yes. Perfect. So this gentleman came to me initially here in October 2017. You can see his A1C was 11.2, and then his initial endocrine visit, we got him on a GLP-1 receptor. We reduced his insulin to eliminate lows, and we avoided SGLT2 inhibitors at the time that I saw him because those drugs lead to, remember the way that an SGLT2 inhibitor works, and we'll talk about this in a few slides, but the way that it works, excuse me, is that you urinate out your blood sugars. And so if somebody has a really uncontrolled high A1C, you're just going to make them go to the bathroom constantly with an A1C that's 11%. An A1C of 11% needs insulin first. Once you use insulin to lower your A1C, then you use these adjuncts to really add on and control blood sugar better. But this gentleman needs insulin. A GLP-1 receptor agonist, it really doesn't cause any untoward side effects other than the nausea, vomiting, and diarrhea. So if their sugars are really high with an A1C of 11%, you can still start that because they're not going to be excessively urinating, causing non-compliance with the drug. So my recommendation would have been to start the GLP, which we did, and reduce his mealtime insulin to eliminate lows. Remember, there's lots of different ways to skin a cat. There's lots of ways to treat diabetes, but I think in this case, or in cases where you see the A1C greater than 9%, I wouldn't off the bat use an SGLT2 inhibitor because they will be constantly urinating. So if we look at the drug trials of our GLP-1 agonists and why they have such great indications, we looked at first the LEADER trial. This was looking at liraglutide or brand Victoza. It showed significant reduction in cardiovascular death, non-fatal MI or stroke for liraglutide versus placebo here in panel A. FDA did grant Victoza or liraglutide a cardiovascular events indication based on the LEADER trial. So also looking at the renal benefits of Victoza, it did reduce the new onset of persistent macroalbuminuria. It reduced a doubling of serum creatinine and patients leading to continuous renal replacement therapy. And that was the composite renal outcome, which was significant with Victoza. So again, I told you these drugs do have cardiovascular benefit and renal benefits. SUSTAIN 6 was a trial that looked at semaglutide or Ozempic and did show a significant reduction in cardiovascular death, non-fatal MI, or stroke. The FDA did approve Ozempic to reduce cardiovascular risk in adults with type 2 diabetes and known heart disease. And if you notice here in the data, the MACE or major adverse cardiovascular outcomes was really heavily reliant on reducing their non-fatal stroke. So the MACE heavily relied on reduction of non-fatal stroke. It did show, primary outcome to be superior as well in terms of reducing cardiovascular death, non-fatal MI, or stroke. Looking at REWIND, this was dulaglutide or Trulicity. Again, Stellar, showed reduction in cardiovascular outcomes, cardiovascular death, non-fatal MI, or non-fatal stroke. The FDA did approve Trulicity up here in your right-hand corner for primary and secondary prevention of major adverse cardiovascular events based on the REWIND trial. So that's really a landmark thing for diabetes care. When we think about caring for our diabetes patients and think about preventing the things that are life-threatening, like a stroke or heart attack, we now have drugs that helps in primarily preventing a heart attack or a stroke in these patients. And so, in my opinion, every single type 2 diabetic should be on, your first line is always metformin, and then GLP-1 agonists to prevent major adverse cardiovascular events, which we know is the most life-threatening thing for patients that have type 2 diabetes. The Excel trial, this was one of the older GLP-1 agonists. It looks at exenatide or Byetta. This did not show superiority or significance in reducing adverse cardiovascular events, but the important thing to point out is that it didn't show any harm, which is very important in diabetes care because, as I pointed out on one of the first few slides, there are drugs that adversely affect the myocardium. So when you're making your choice on agents to use, you certainly want to use agents that have benefits. And then if you can't use one of those, you want to use an agent that doesn't have harm. Elixa was lixisenatide or Lamixia. This was an older drug as well. Again, didn't show superiority, but also did not show any harm. And this slide just shows the y-axis that's blown up in the center there for you. Pioneer 6 looked at the newest oral semaglutide, which is called Rybelsus. This kind of fell short. We were really hopeful that this would show a reduction of cardiovascular death, MI, or stroke, and it did not. However, again, it did not show harm, which is also very important. And so if my patients do have cardiovascular disease, I do not use Rybelsus. I typically use the injectable GLP-1 agonists because they do have data that shows cardiovascular benefit, whereas Rybelsus doesn't show harm, but it didn't show the same benefit that the injectables do. Harmony looked at albuglutide or Tanzium, which is now off the market. It did show a significant reduction in cardiovascular death, MI, or stroke. So to look at the kidney outcomes of GLP-1 agonists, I just put this slide here for you to understand that yes, GLP-1 class does help kidney function. So the LEADER trial showed, reduced macroalbuminuria. Sustain 6 showed a reduction in new or worsening nephropathy. Elixa studied show reduction in urine albumin to creatinine ratio. And so the GLP-1 agonist as a class does have improvements in renal function. Case 2. Anybody have questions?
Yeah, I had a quick question.
Sure.
So for a new diabetic, would you go in and just start metformin if their renal function was appropriate, or would you just straight out the gate start metformin and GLP-1?
Awesome question, Melissa. So I'm going to go through that in a couple of slides I think it's at the end. I put in the ADA algorithm for care when you guys are in your clinics. Metformin is still first-line therapy for type 2 diabetes, but I will say that metformin, we know that it does not have the cardiovascular benefit and the renal benefits that the GLP-1 and the SGLT2 classes have. So you'll see in the ADA algorithm, always first line is metformin, diet, exercise. And then after that, does your patient have cardiovascular disease, renal disease, or heart failure? And it kind of breaks them into tiers. And we'll go through that in a little bit more depth. But in my own clinic, yes, I do rate metformin first. Part of that, unfortunately, is insurance purposes too, because insurance really, that's our first line drug. And so if they're not on metformin, insurance will appeal that and say, please try metformin first before you try add-on therapy. So yes, most of my patients are on metformin, but if a patient, say they come in, their A1C is controlled, they are on metformin, their A1C is 6.5%, and they have cardiovascular disease, or they have renal disease, I add on these therapies. Because remember, they do not cause hypoglycemia themselves. They can cause it if added to drugs like insulin or sulfonylureas, but independently, these drugs do not cause hypoglycemia. But they have been proven to have primary and secondary cardiovascular prevention, so I do add them. Does that answer your question?
Yes. So, well, one other thing. So if they're controlled on metformin and they don't have any diagnosed like cardiovascular, renal, or CHF, you just kind of hold off on starting any of the GLP-1s?
I also look at, there's so many other things that kind of come into play too. So a lot of our patients that have type 2 diabetes struggle with weight control. And looking at the history of GLP-1 agonists as a class of drugs, they were first introduced to control blood sugar, but they were shown to reduce weight and help with weight loss, so much so that pharmaceutical companies got smart, and so they remarketed the drug. And you probably have heard of that, called Saxenda. That's a drug class that is only used to treat obesity. It has nothing, they have no diagnosis of type 2 diabetes, but they're solely being treated for obesity. Saxenda is used to help with weight loss. And Saxenda is liraglutide. It's just a much higher dose. Liraglutide is Victoza. So it's just a much higher dose. And so if somebody, say, is struggling with weight, which in my clinic, I see, type 2 diabetes patients who are severely uncontrolled, have a lot of, weight issues. You'll see in my next case, I see a lot of patients with a BMI well beyond 30. And so I do add a GLP-1 agonist, maybe if they don't have heart failure, coronary artery disease, or renal disease, but to also help with sugars and assist with weight. So again, it's not a one size fits all for everyone. I will go through this algorithm with you at the end from the ADA to help you guys in your clinics make these decisions. But yes, I do add on GLP-1s outside of renal disease, heart disease, and heart failure, atherosclerotic disease.
Thank you.
Sure. Case 2, Joe heart failed. He's 38. He's a Caucasian male, comes in for uncontrolled type 2 diabetes. He's referred from heart failure clinic. His A1C is 9.2. His blood sugar trends show improved control since he began metformin. His blood sugar now is 150 to 170. He has no type 2 diabetes complications to date. His cardiac history shows newly diagnosed non-ischemic heart failure. He has no history of atherosclerotic cardiovascular disease. He has hypertension, hyperlipidemia, and sleep apnea. He's only on metformin 1 gram twice a day. Vitals look okay. He is obese, and his GFR is normal. What do you want to do with this gentleman? Start a GLP-1 receptor agonist and continue metformin. Start an SGLT2 inhibitor and continue metformin. Stop metformin, blood glucose looks awesome. Start Januvia, continue metformin. Do nothing, send him back to cardiology and tell him that his cardiabetes is controlled. Okay, so let's go back to one key thing in here. So he has non-ischemic heart failure. Whenever you see a diabetic patient, in your mind, think, do they have atherosclerotic disease? Do they have heart failure? Or do they have renal disease? And sometimes they have all three. In this case, he has heart failure. He doesn't have blocked arteries, and his GFR was normal. So in his case, the next best step would be an SGLT2 inhibitor. So His A1C was borderline 9.2, but I want you to understand that the FDA has approved these SGLT2 inhibitors simply for heart failure alone, even in patients that do not have diabetes. An SGLT2 inhibitor treats heart failure and prevents rehospitalization from heart failure. So in his case, we started an SGLT2 inhibitor and continued metformin. It's not that a GLP-1 receptor agonist would be wrong, and I would probably also add that on. He was started on his SGLT2 inhibitor, and he did phenomenal, and his A1C came down to 6.1%. And he lost a lot of weight on the SGLT2 inhibitor. That works kind of like a diuretic and helps with decreased weight loss through, it's like a diuretic effect. So the SGLT2 inhibitor classes, they're the gliflozins. So generic is over here on the left, brand is over here on the right. Zooming in on our ADA chart, if we look a little bit closer, these do not cause hypoglycemia. They help with weight loss. They are tremendously beneficial for atherosclerotic disease and heart failure. Again, they have a sole indication from the FDA to treat heart failure alone. So if your patient has heart failure plus diabetes, this is a really great drug, because even if your patient doesn't have diabetes, they still can be treated with these drugs. Unfortunately, the newer agents are higher cost. It's always an issue getting drugs appealed. I don't have a magic solution for that. Renal effects, they do benefit the kidney tremendously. Reduce microalbuminuria, reduce protein in the urine overall. Tremendous renal benefits, and I have some slides to delve into that a little bit more. Some considerations to just remember: if your patient's going to go into the hospital and get a surgery, they should be discontinued on this because there is a risk of DKA in your type 2 diabetes patients. It's rare, but nonetheless something that they need to know about. If your patient just goes into DKA on these patients, you can see euglycemic DKA with these drugs, then I would recommend stopping the drug. It is rare, but something that your patient needs to know. There was a risk of bone fractures reported in only canagliflozin that's been heavily disputed. There was a study by Iannucci, I believe, that has disputed really this bone fracture class effect. So it has, the fractures have not been seen with the other drugs like Farxiga or Giardiance. And so I tell my patients, you know, the bone fracture data was with canagliflozin. It doesn't seem to be a class effect of the drug, and I still do recommend it, even if patients have had a history of bone fractures, because remember, you know, diabetes itself is a risk factor for bone disease. Okay, so it also causes genitourinary, like yeast infections and urinary tract infections overall. Rare, but can be seen with Fournier. You can see Fournier's gangrene. I tell patients two urinary or yeast infections in a year and we stop the drug, or one that's very severe and requires hospitalization. Again, type 2 diabetes patients, or any diabetic patient, I'm focusing on type 2 diabetes here today, but any diabetes patient has a higher risk of infections overall. And so at baseline, they're at a higher risk for genitourinary infections, but if they get more than 2 a year, I stop the drug. To look a little bit more in depth at the SGLT2 inhibitors, again, we talked about weight loss, blood pressure reduction. They have incredible renal and cardiovascular benefits, specifically with heart failure. We talked about the risk of fractures, infections. They can cause excessive urination and volume depletion because of their diuretic effect. So use with caution in a patient that is in heart failure, that is actively being diuresed in the outpatient setting, because you really want to talk to their PCP or their cardiologist to make sure that their diuretics may need adjusted if they go on these drugs, because these drugs do act like diuretics. They have a bump in the LDL, but that's never been something that I feel prevents me from using the agent. Most of our patients with diabetes after the age of 40, the indication is for a statin. And so I typically am writing a statin along with the SGLT2 inhibitor. And we talked about DK and Fournier's gangrene to be aware of. SGLT2's inhibitors have wonderful benefits on the heart, decreasing sympathetic outflow to the heart, decreasing sympathetic outflow to the vessels. We'll talk in depth. I have a slide only on the kidney, but multitude of effects that you can see here on the heart, vessels, and kidney. This is the tubuloglomerular feedback system in normal physiology A, diabetes, and then diabetes after treatment with an SGLT2 inhibitor in C here. And so the way that these drugs are proposed to work is that instead of you delivering your sodium to your distal nephron, you have increased sodium and glucose reabsorption, the paroxysmal portion. And so the distal portion sees decreased sodium delivery to your macula densa. Because of that, your afferent arteriole vasodilates instead of being very vasoconstricted, causing hyperfiltration and damage to your kidney. And so the mechanism of action is thought to be really related to this sodium delivery and the lack of distal sodium delivery to the distal nephron, leading to afferent arterial vasodilation and prevention of damage to the kidney. So to review SGLT2 inhibitor trials, we'll talk about EMPA-REG, CANVAS, DECLARE-TIMI, and DAPA-HF. Does anybody have questions? Okay. EMPA-REG looked at empagliflozin or Giardiance. Phenomenal reduction in cardiovascular death, non-fatal MI or stroke. You can see significant findings in that primary outcome in panel A. Death from all cardiovascular cause, any cause, and hospitalization for heart failure were all reduced. This led to the FDA to approve Giardiance to reduce cardiovascular death in adults with type 2 diabetes. Canagliflozin or Invokana also showed a reduction in death from cardiovascular cause, non-fatal MI, or non-fatal stroke seen here in panel A. DECLARE-TIMI, again, same data, reduced cardiovascular death or hospitalization from heart failure, reduced renal adverse outcomes, reduced proteinuria. This led the FDA to approve Farxiga to reduce the risk of hospitalization for heart failure in diabetic patients. Credence looked at canagliflozin or Invokana, showed significant findings, a reduction in end-stage renal disease, a doubling of a patient's serum creatinine, reduction in renal or cardiovascular deaths. DAPA-HF showed Farxiga reduction in outcome of worsening heart failure or hospitalization, or an urgent need for IV therapy for heart failure, so IV diuresis, or death from cardiovascular causes. So you can see the SGLT2 inhibitors have tremendous benefits for heart failure and renal disease. Melissa, this is the slide I was referring to from this is the updated January 2021 guidelines for treatment of our patients with diabetes. So you look up here to your top blue bar, and your first line therapy is metformin with diet and exercise, weight changes, weight loss clinics, referrals for carb counting, and obviously we always want our patients to change lifestyle. If that's not fruitful, the left side that's highlighted, you look over here to the left column, it says indicators of high risk or established atherosclerotic cardiovascular disease, CKD, or heart failure. In the blue, on the very left-hand side, if your patient has established atherosclerotic cardiovascular disease or high risk, you want to consider your GLP-1 receptor agonist that has proven cardiovascular benefits. Sorry, I'm on call, so I keep checking my watch. I'm not watching it for the time. I'm just on hospital call. So you want to make sure that you're using agents that have proven cardiovascular benefit out of our GLP-1 class of agents. If your patient has heart failure in the red, ejection fraction less than 45%, You want to consider an SGLT2 inhibitor. Remember, they act as like a diuretic and promote natriuresis. If your patient has CKD, you want to use either a GLP-1 or an SGLT2. SGLT2 inhibitors have a little bit better and more robust data for reducing CKD progression. And so anyone, type 2 diabetes, CKD, SGLT2 inhibitor is your go-to. So now we go over to the right side here. You see in the like yellowish green. And this is kind of what I was speaking to earlier, Melissa. You know, say your patient is really trying hard to, you know, lose weight, for instance, right here in the kind of light blue. Then you'd consider add-on therapy with your GLP-1 receptor agonist or your SGLT2 inhibitors, which we know help with weight loss. You want to avoid things like insulin, sulfonylureas, TZDs. Those things all promote hunger and weight gain. If you're trying to save money, absolute worst case scenario, we have to write for sulfonylurea or a TZD. I really do not like these drugs. The sulfonylurea is predisposed to hypoglycemia. They are cheap. Many patients have been on them and want to stay on them because that's what they're used to and they are cheap. But sulfonylureas don't really do anything to benefit your heart, your kidneys, and again, they predispose to hypoglycemia. I don't really recommend them for elderly patients either because of the hypoglycemia risk. TZDs, they are also cheap, but I presented the one slide earlier from the New England Journal of Medicine that TZDs previously, you know, they cause fluid retention and weight gain. So you really want to be cautious in patients that have cardiovascular disease with either of these two. But if, you know, the patient is free of cardiovascular disease, younger, healthier, and cost is a major issue, that's definitely something to consider. I mentioned this, but if you want to avoid hypoglycemia, you know, the big agents that cause hypoglycemia are insulin, sulfonylureas. So using any of these in the orange would be an option to avoid hypoglycemia. So when you're in clinic, to make this like simple and kind of boil down a lot of data, I kind of put this over here on the left-hand side. So choices, choices, choices. Think, you know, my patient, do they have atherosclerotic disease? Do they have heart failure? Do they have kidney disease? And you can, from there, use your algorithm to figure out kind of stepwise what your patient should be on. If they have atherosclerotic disease, remember GLP-1. If they have heart failure, remember SGLT2 inhibitor is better. If they have kidney disease, SGLT2 inhibitors. And then you can add on agents beyond that. And certainly if they're really uncontrolled, you know, greater than 9%, insulin is your best drug, because remember, these drugs are really adjuncts and they help with a multitude of things. But if your A1C is above 9%, insulin, it doesn't have a ceiling on how low you can bring your A1C down. So you want to give them insulin. You don't necessarily have to give them insulin forever. It's not a life sentence, but you want to give them insulin and bring down their A1C, and then add on pills as adjuncts to help with weight loss, to help with their heart, to help with their kidneys. Oh, sorry, I have to wrap this up. I just was getting a chat here, so I think I only had one more slide, which I really went through this in summary. If anybody has any questions, just let me know.
Thank you so much, Dr. Giordano. Yeah, I did not want to cut you off. You're on a roll there.
No, Miss Hart, you always cut me off. It's okay. I'm losing my voice, so I appreciate you.
Oh, thank you so much. We really do appreciate it. And we have a few minutes here too. So if there were any questions for Dr. Giordano, please feel free to unmute anyone. This is safe space and open platform for all. So feel free to unmute and ask away. Thank you. Alrighty. Well, I don't want to keep you guys any longer, but if there were any questions after the fact, please feel free to email me, shoot me an email, and I'll make sure to have them addressed or even send them to Dr. Giordano's way as well. So thank you all so much. Our next session will be on February 10th, and Renee is going to be talking about social determinants of health. So keep an eye out for that reminder, and we'll see you guys next time. Thank you, Dr. Giordano.
Thank
My
you.
pleasure. Take care.
Thank you so much.
Take care. Bye-bye.